So coming back to third case, in view of time we are chasing. I'm extremely sorry, but that's how it has been instructed to me. It's already late. Again, a 39 years old, again G4. Now this is from G1 primary to G4, P1, L1, A2, 26 weeks of gestation to the ER with a 2 days history of pain abdomen, headache, oliguria, and on examination drowsy, erosible, icterus, bilateral pitting edema, hypertensive with 160/90, tachycardic, no meningeal signs, power in the limbs were normal. So I don't know, maybe I think this is an OBG part, so I just went back. We no discussions, no take-home points there. This patient was wheeled down to get an LSCS done and shifted to ICU. So based on these findings, so what will be our differential, Jayanti ma'am?
She's 26 years and she's having oliguria.
26 weeks.
Sorry.
Yeah. 2 days of oliguria, abdominal pain, headache.
And then she has this abdominal pain and headache. Am I dealing with a case of an, because the BP also is raising?
Yes.
Is it a case of an acute renal failure? Or is it, and she's also having icterus. So am I dealing with a fulminant hepatic failure? So these are the two things that, because they're in the mid-trimester, more common.
So what will be your differentials? Is it you're talking about a AFLP, you're talking about HELLP?
I am thinking of HELLP syndrome.
Any other options, ma'am?
I think AFLP also I'll be thinking here.
Anita ma'am, anything else?
And in the early weeks, I mean generally after 20 they present, but it's been too early. Are we working on any other things of, serology, the other things are not available. Have we missed on any other infective conditions also apart from the hypertension, microangiopathy conditions?
So we will give you a little more information. The labs came back, the creatinine was high, urea was high, evident of AKI, peripheral smears talking about cystocytes, high LDH, and lactates were high.
So that is something suggestive of microangiopathy, thrombotic microangiopathy.
There were no debates. The approach was right. They pushed the lady directly to the OT, delivered the baby, and the patient was transferred to the ICU. That never ended the story there. We always think that is so simple. And this is the case with us. The patient further worsened after the cesarean section and rapidly deteriorating. And that's what happened. This is as we expected, cytopenia, thrombocytopenia, OTPT elevated, hemolysis, probably HELLP, clear-cut case, hypertensive, delivered, should be improving. Not happened in that way. Received in the ICU, further worsening of lactate, further worsening of AKI, coagulopathy worsened, and now comes the dilemma. I'm sure 80%, 90% may be so simple that they improve immediately, or they stabilize at least, take a day or two to improve, but worsening was something which was worrying for us. There were issues again, where post-operatively we see suddenly the coagulopathy further worsened. The INR at admission was high, and it further worsened on the post-operative period, and the drain output increased, abdomen started being distending. Again, as we were discussing that day, the previous case, we invited Nikhil. So Dr. Nikhil was our rescuer every time with our OBZ team. It's always a teamwork, okay? Gone are those days where we say, this is our case, that is our case. It's all teamwork, and we are thankful, grateful. We have OBG clinicians. I have seen Dr. Anita ma'am during my school days, people were talking about Jayanti ma'am being their inspiration. We had Dr. Krishnaveni and other clinicians who have been such a dynamic support. They will be standing there talking to you, saying what will be the next plan, keeping the whole of the wisdom Pandora box open. And this is the kind of obstetricians we will love to have with us in the ICU, because that's how the clinical outcome will be. They always take care of that side, and they will ask questions to us, what next? So it is a time where we actually invited Dr. Nikhil. Nikhil, your experience on this case?
Sir, if I remember properly, the drain output was totally hemorrhagic, and also we calculated the hemoglobin from the drain, and it was equivalent to the blood hemoglobin that was there in the body. So it was whatever was leaking was directly coming out, and so it was a no-brainer that she had to go for embolization, otherwise we would be left with no other choice. So we can discuss the CT.
So these were all kept in the mind. HELP, AFLP, DIC and TMA during when this patient was ongoingly bleeding and things were not helping. Yeah.
So this is the CT where we can see that there is a drain in the anterior abdominal wall and there is layering of fluid collection that is there, which again suggests that there is active bleeding. And in the third image where we can see just in front of the Foley's bulb, there is a collection with active contrast leak that is there. So the patient was continuously losing blood, but unlike the last case, there is no large hematoma that is there because the drain is continuously draining the blood that is collected. So we did not have significant abdominal distension there, and we went in, and basically not in every case we would see active extravasation on the angiography. So it may be because of delayed venous ooze, or while I have taken up for embolization, the patient may be in hypotension or the vessels may be in spasm. So we need to empirically go in and block the bilateral inferior epigastric arteries, which are the source of the incision site bleed for the abdomen, as well as the incision site for the uterus, which would be the uterine artery. So these are the images of bilateral inferior epigastric artery which were embolized. The first image is of the external iliac artery injection. Second one is a selective injection of the inferior epigastric. And the third is post-embolization of the inferior epigastric. And next slide, please. Similarly, we go into the bilateral internal iliac arteries, selectively cannulate the uterine arteries and block them. So the third image is post-embolization, where there is absolute stasis within the uterine arteries.
So just to keep the discussion on, that was a damage control, but what was the diagnosis? We all kept it very simple, saying possibly this was a HELLP syndrome, and we delivered the baby, and then we worsened everything. After the delivery, the coagulopathy didn't correct, things worsened, lactates kept on worsening. So thinking about HELLP, no previous history of hypertension, no improvement of the delivery, but as ma'am said, the partial HELLP and HELP during peripartum period is not uncommon, and it is well documented. So we all take that possibility still on. AFLP, yes, again, it's too early for the pregnancy, around 20-26 weeks. We generally see in the third trimester, it's not uncommon. It's uncommon to have an early pregnancy. This patient never had any encephalopathy, and Swansea criteria, which we use to actually document a AFLP, was not actually suiting to a AFLP in this case. No hypoglycemias or initially to see. DIC, is there any possibility that, as I said, will be an end pathway of any possibilities? You come from anywhere. So that possibility will be on low fibrinogen coagulopathy bleeding. TMA, thrombotic microangiopathy. So renal shutdown with a situation like this, and the TTP is not fitting because plasmic score with encephalopathy is not there, more of an AKI. And we were also discussing after the embolization, the AKI kept on worsening, the cystocytes never came down, and there was a discussion, can this be a possibility of atypical pregnancy-induced HUS? And then there came a different discussion. Ma'am, any take-home points in this case? Dr. Ravi, you want to start with that, why you are talking about a atypical HUS in this case?
Yeah, this was a classical case, where there was a lot of debate between the, nephrologists, the critical care team, because if you look at the first picture, everybody is carried away by the fact that, there is hemolysis, there is elevated liver enzyme, there is a low platelet, and with a classical history presenting with the high pressure, so we thought we'll terminate, things will settle. It didn't settle. Then there is a second insult or an event in the form of a DIC. Then we believed that, okay, she has lost quite a lot of blood because of the bleeding, so let us correct it, it will settle. But it never settled. But we are not able to explain the cystocytes in the smear. So at this point, what we thought was probably this could be a thrombotic microangiopathy, which we commonly see in the pregnancy. So we have given her a session of plex. But generally, we would see a response to the plex. And what was another atypical feature here was a presence of AKI, which is not very commonly seen with the TTP. So that is where we thought it could be a HUS. So HUS classically presents with an acute kidney injury, needing a hemodialysis support. So benefit of doubt, whenever such a situation comes across to you, you can always give a trial of plex. If the patient is not responding to plex, probably this patient is in the spectrum of atypical HUS. If you look at, she has HELLP, she has DIC, she has atypical HUS. This is an overlap of the 3 different disorders presenting in the same patient.
Plex is a plasma exchange. It's I think a trial of plasma exchange has been attempted in this case. So what actually we try to learn, if you see any conventional textbook of OBZ from my medical school days to till today, including up to date or any of our critical care courses on OBZ, it classifies. Can it be a AFLP, can it be HELLP, can it be a DIC with PPH, or can this be a HUS or a TTP? And they are all been categorized one after the other. Hypoglycemia this side, hyperbilirubinemia this side, encephalopathy, coagulopathy this side. So we kept on debating in the last decades whether it is a HUS, TTP or HELLP and all. It's no more valid. That's the message in this case. All of them can be together. There is no need of debate. Your HELLP is there, obviously looks clear. Patient not responding to the conventional therapy of delivering the baby. Patient is an oliguric, anuric, and the patient continues to have a cystocytes and ongoing hemolysis with hyperlactatemia. There is a possibility of a thrombotic microangiopathy. The confirmation most of the times they get if a patient remains to be oliguric or anuric or needing a dialysis, they do a renal biopsy and they confirm it. The HELLP and TMA remains an overlap. And if you go back to your up-to-date and go through that, the overlap percentage is quite common and good amount. It's not very clear that this is HELLP and this is TMA. So the message here, overlap is not uncommon and that should be kept in mind.